Okay, I don't want to cut into the speaker's time, so I might as well get started, right? So it's my pleasure today to introduce our Grand Round speaker, Dr. Rob Bechara from Queen's University in Kingston. Dr. Bechara did his medical training and gastroenterology training in Toronto and Kingston before doing therapeutic endoscopy at St. Michael's in Toronto. And then after that, he went for 1 year to Tokyo, Showa University with Haru Inoue, who's the first person who did per-oral endoscopic myotomy in the world. And so since then, he's come back and joined faculty at Queen's University. And he's going to speak to us today about endoscopic submucosal dissection. It's back to the future. Looking forward to a good talk. Rob?
All right. Thanks, Eric. Thanks for the invitation. And I'm really excited actually to be there next week in person and meet some of you and get to see some interesting cases. So I'll just go over my objectives. I really just want to go over the methods of GI tissue resection. So endoscopic mucosal resection, ESD, and surgical resection. And I want everyone to be aware of the indications, risks, and benefits, and some of the complications of ESD, and some of the obstacles in terms of implementing ESD in Canada. So we'll go over a couple of cases initially. So we'll go over an esophageal squamous cancer, a dysplastic Barrett's, a early gastric cancer, and a colonic adenocarcinoma. And then we'll just introduce EMR and ESD. So the first case is a 50-year-old lady. She had a history of type 3 achalasia that was previously treated with pneumatic dilation. She did well for a number of years, and then she was re-referred due to recurrent symptoms. And this is her endoscopy here. So with white light, you can kind of see there's a lot of contractions going on, and then there's also this abnormality here. And we can also use different types of light with endoscopy, and they help highlight different features. This particular light helps highlight the vasculature, which is kind of the earliest things that change with squamous carcinoma. And you can see these vessels here with this light are really well highlighted. We can also use Lugol's, and Lugol's basically stains normal squamous mucosa, kind of this dark mahogany color, and dysplastic lesions kind of are Lugol voiding lesions, and they appear as orange, or if you wait a bit longer, they can turn pink. It's usually indicative of carcinoma. So based on our examination in this particular case and the examination of the vessels, there's different classifications we can use with magnifying endoscopy that allow us to predict the histology. And based on what we found, we thought it was a superficial carcinoma, so M1, M2, which I'll show you in a second exactly what that means. But this abnormal area, we thought maybe it was a bit deeper based on the classifications that we have. And this just shows you for squamous carcinoma, the relative risk or the risk of lymph node metastasis based on the depth. So M1 carcinoma means it's in the epithelium, M2 means it goes into the lamina propria, and M3, it goes into the muscularis mucosa. And then you can see the risk here in terms of lymph node metastasis. So it's quite low for these M1, M2 lesions. So generally for those, endoscopic resection is a good indication to remove it with. For M3, SM1, because the risk is a bit higher, and again, it varies a fair bit, it's a relative indication. And for deeper carcinoma, so in the superficial submucosa, these numbers here basically vary depending on the area of the GI tract, but basically it's the first third, second third, and the distal third of the submucosa when we talk about SM1, SM2, SM3. And for squamous mucosa, the SM2, SM3 generally should be managed surgically because of the significant risk of lymph node metastasis. The next case is a 63-year-old lady with a history of Barrett's esophagus, initially discovered in the community in 2014. And endoscopy at that time showed, and biopsy showed high-grade dysplasia. She was then referred to another tertiary center, and they subsequently did EMR, so endoscopic mucosal resection. This just describes the length of the Barrett's, how much is circumferential, and the maximum extent. And she had intramucosal carcinoma. So after the resection of the carcinoma, they tried to ablate the Barrett's, which is the standard of care, using radiofrequency ablation. Unfortunately, she didn't respond particularly well in that she didn't re-epithelialize to normal squamous. There were still Barrett's remaining. So she was subsequently referred for esophagectomy. At that time, she lived closer to Kingston in terms of the surgeons, so they sent her back here, and the thoracic surgeon discussed surveillance versus esophagectomy. She opted for surveillance. And a couple of surveillance endoscopies went by. She didn't have any dysplasia. And then finally, again, dysplasia showed up on her endoscopy. So she was then referred back from the community to our center and to thoracic surgery for esophagectomy. And then he sent the patient to me. We share a lot of patients, and it's quite nice. We have a good relationship with our surgeons, but it basically asked, are there any endoscopic options? And based on our examination, we thought there was low-grade dysplasia, high-grade dysplasia, and buried Barrett's. And buried Barrett's basically means there's Barrett's underneath what appears to be normal squamous mucosa. So it can be a bit challenging to detect and also treat. So this is just a quick endoscopy showing you the distal end of the Barrett's. So this pink area is the Barrett's esophagus. Then you have this kind of a whitish mucosa, which is normal squamous. And then again, some Barrett's esophagus up here. And you can see it with the different modes of light. Again, it helps characterize things a bit better. But based on our examination, as I mentioned, we thought it was low grade, high grade, and some buried Barrett's. For esophageal adenocarcinoma, generally the risk of lymph node metastasis is quite low from M1 to SM1. So those are generally good lesions for endoscopic resection, whereas the deeper lesions, SM2, SM3, have a higher risk, and they generally should be managed surgically. So now we'll go over kind of the traditional surgical treatment of these two particular cases, which would be with esophagectomy. And the mean length of stay in Ontario, anyway, is about 17 days. The adverse event rate is about 33%, and the mortality varies in terms of high volume centers versus low volume centers. The high volume centers, anywhere from 3 to 8% in terms of mortality. The low volume centers, about 16 to 23%. And in terms of the complications, this just shows you some of the surgical complications. So anastomotic leaks, conduit necrosis, chyle leaks during the procedure, obviously bleeding. Some of the medical complications, probably the more common ones, are arrhythmias or myocardial infarction after esophagectomy. But you can see it's a fairly extensive list. In terms of costing, so this will obviously vary from province to province, but to give you an idea for us in Ontario, the funding per case of esophagectomy is roughly about $60,000. The case costing at our center comes out to about $20,000 per case. So this case was a 66-year-old lady. She was referred after having some nonspecific abdominal discomfort and bloating. So she was going to have an upper endoscopy to rule out celiac and H. pylori. Random biopsies were taken for H. pylori, and then a single biopsy came back and showed signet ring carcinoma. So she was then sent to me to assess endoscopically. And this is the area where I saw an abnormality in the stomach. So again, kind of the similar principles. We examine things with white light. And you can see here there's a little bit of an abnormality. It's a bit different from the background. We examine it with, again, different types of light that allow us to characterize things a bit better and delineate things a bit better. And then again, with this light that highlights the vasculature, you can see this area is abnormal compared to the background. And then with magnification, we can see some findings that are indicative of signet ring carcinoma. I won't go into those details, but the magnification really allows us to characterize things a bit better. And there's some good markers that indicate the type of cancer it is endoscopically, which you can see here. And this just shows you the importance of cleaning when you do an endoscopy. So when we go in, there's a lot of bile staining, and this lesion is actually just underneath the bile. So if you do a very quick and gross exam, these are types of things that can be missed. So this is a bit of an oversimplification for gastric cancer. It's a bit more complicated. It depends on size and differentiation and some other factors. But generally for gastric cancer, again, M1 to SM1, so these superficial gastric cancers, the risk of lymph node metastasis is fairly low, and these can be managed endoscopically, whereas the deeper invasion should be managed surgically due to the significant risk of lymph node metastasis. And in this particular case, it would have been a total gastrectomy, and the average length of stay is about 10 to 12 days for open, 4 to 8 days for laparoscopic, and adverse events is about 5%, but across Ontario, it's anywhere from 0 to 16.7%. And the morbidity, again, in terms of overall, complication rates, about 15%. So this last case was an 85-year-old lady with a previous right hemicolectomy and a left segmental colectomy for 2 synchronous colon cancers about 10 years ago. On surveillance endoscopy, she was found to have this lesion over here, just at the rectosigmoid junction. And this just shows it to you here, again, in different lights. But based on our examination, we thought this would be, again, superficial, likely a superficial carcinoma rather than a deeply invasive carcinoma. And for colonic adenocarcinoma, again, similar trend in that superficial M1 to SM1, generally a definite indication for endoscopic resection, and SM2, SM3, generally surgically managed. SM2 is a relative indication because the kind of intermediate risk of lymph node metastasis. However, that data is actually based on studies from the past where they didn't stratify according to tumor characteristics, such as lymphovascular invasion, tumor budding, differentiation. So a number of studies have come out in the past 10 years or so that have basically taken tumors that have had all good tumor characteristics except for the depth of invasion. And this shows you that the risk of lymph node metastasis, even when it's greater than that cutoff, I showed you about 1,000 micrometers in the colon, that the risk of lymph node metastasis is not that high. And we may see expansion of the criteria for endoscopic resection in the future, but it's not there just yet, but there's more and more data kind of coming out. So in that particular scenario, that patient generally would have been treated with a low anterior resection. And with low anterior resections, open is about a 4 to 6 day hospital stay, laparoscopic 3 to 5, and robotic surgery only 2 to 3 days, which is quite impressive. The mortality within 30 days is less than 2%. So overall, it's a fairly safe procedure. The adverse event rate is about 10 to 15%, and it varies from cardiovascular to, again, kind of primary surgical, such as anastomotic leaks and bleeding. And in Ontario, anyway, the hospital funding for these procedures is about $15,000 per case, and the cost is between $9,000 to $12,000, at least at our center. So now I'm going to move on, and we'll talk about endoscopic mucosal resection and endoscopic submucosal dissection. So in terms of the evolution of the treatment of removing GI neoplasia, it really started in 1969 in terms of endoscopic resection. So Dr. Hiromi Shinya performed the world's first polypectomy of about a 1.5 centimeter polyp in the sigmoid colon. And then he published his experience of the first 100 polypectomies in the New England Journal of Medicine in 1973. And here you can see his drawing really of a snare, and things haven't changed very much since then. They're very similar in terms of how they look and how they operate. But over the decades, EMR has evolved a little bit, not too much, but it has evolved a little bit. So we have some techniques where we use a cap, we inject some fluid underneath the lesion, we suction the lesion into the cap and snare it off. And then we can also just inject underneath the lesion and then just put the snare around it and cut it off. And this is typical of what we do for colonic lesions. So endoscopic mucosal resection is really the treatment of choice for dysplastic gastrointestinal lesions. It's quick, it's safe, and it's effective for most cases. And I'll show you an example here of an en-bloc EMR. And it shows you here the gross specimen and then the histology. So this is a sigmoid polyp, about 1.5 centimeters, probably very similar to the polyp that Dr. Shinya removed. So we injected some fluid underneath it. and then we put our snare around it, and we kind of put it just at the base of the lesion, and we close, and then we'll check kind of our mobility, make sure we're happy with what we've got, and then we use electrocautery and cut through, and then you see the defect there. This is an example of an EMR in the esophagus. So we have this transparent cap, and we have this little tiny carcinoma here. And again, we inject underneath it. And then what we do is we suction it up into that distal attachment, this cap here. And then we have a snare that we rest just on this edge of the cap. And then after we suck in the lesion, we close the snare. And then the same thing is we apply electrocautery, and then the lesion is cut cleanly off. Then we have piecemeal EMR. So when lesions get larger, we can't remove them in one piece using this technique. We have to move them in multiple pieces. And when we remove them in multiple pieces, these are the types of specimens you get and the histology. And it can be difficult or impossible for the pathologist to tell you in terms of the vertical margins and lateral margins when it's removed this way. So that's one of the issues with ESD or EMR, sorry. So here's a lesion in the ascending colon. We injected some fluid underneath it, and same principle, we get our snare around it, we close, we kind of check our mobility, make sure we're happy with what we've got, and then we cut the lesion. And then we're going to repeat this process over and over to remove this large lesion. So we injected some fluid again. We're going to put the snare around, close, and then again use electrocautery. And you'll see we're able to remove this fairly large lesion, that's maybe 6 centimeters or so, in the end, cleanly and relatively quickly using endoscopic mucosal resection. So traditionally in Canada, we've had EMR and surgery. And EMR is really a good treatment for patients with low-grade lesions, with low-grade dysplasia, or very small early cancers that can be removed in one piece. Surgery, on the other hand, is really the best treatment for patients with invasive cancer, where the risk of lymph node metastasis is significant. And the risks may not outweigh the benefits for some of these superficial cancers or non-malignant lesions. So this is a busy slide, so I won't go into too much detail in it, but basically it's from a systematic review of about 22 different series from 2006 to 2012 of about 3,000 lesions or so over about 6 years. And it just shows you the recurrence rate as well as the for piecemeal and en-bloc resection and the requirement for additional treatment, whether it's endoscopic or surgery, for lesions that are removed via endoscopy that aren't deeply invasive cancers. So the bottom line really for this study is, as I mentioned, anywhere between 0 and 18% in terms of recurrence for en-bloc, 5 to 35 for piecemeal. And some people might say, well, those are older studies. We have new techniques now that decrease the risk of recurrence, such as burning the edges after we remove it piecemeal. So these are 2 studies from 2 expert centers, one in London, this one here, and one from Portugal. The London series was 456 patients, and they used measures such as burning the edges. They used hybrid ESD, which basically it's kind of in between EMR and ESD, and it's thought to have a decreased recurrence rate afterwards. And they had an overall 15% recurrence rate. The group from Portugal had about 160 patients in their series, and the recurrence rate was about 11%. And again, they used adjunctive measures such as burning the edges, either with a forceps or argon plasma coagulation. So overall, what we can kind of take away from EMR is that the local recurrence rate overall for en-bloc EMR is about 3 to 5% from the literature, and piecemeal resection is about 10 to 15% recurrence rate. The perforation rate is about 1%, and again, it varies depending on the location and lesion complexity. Delayed bleeding, about 5%, and overall additional surgical resection is required in about 10%. And again, that varies depending on your practice and how aggressive or how conservative the endoscopist is. And in terms of the cost for EMR, it's about $150 to $450, and the hospital funding in Ontario is about $1,000 per case. So the advantages of EMR are that it's quick, it's easy, it's cheap, and overall it's very effective for the appropriate lesions, and training is available in Canada for EMR. However, the disadvantages of EMR are that you can't evaluate the margins when it's resected in piecemeal. So larger lesions, when you remove it in multiple pieces, the pathologist can't really tell you about the margins. And if there's severe scarring, you might not be able to remove it via EMR. And as I mentioned, the recurrence rate is about 10 to 15%. And if superficial cancer is found in the EMR specimen when it's removed in pieces, these patients often end up requiring surgery because the pathologist can't confidently tell us the margins. So now I'll move on to ESD, or endoscopic submucosal dissection. So ESD involves cutting the submucosal fibers underneath the lesion to allow us to remove the lesion en bloc, regardless of how big it is. And it was initially developed in Japan to eliminate the size limitations for endoscopic en bloc resection for early gastric cancers. So this was developed actually in the early 1990s. And then it was expanded for esophageal and colonic lesions in 2000 in Japan. And during this time, a lot of people in the West, including Canada, the US, really kind of didn't want to hear it and really weren't interested. And really, we pretended that it kind of didn't exist. And despite this, it slowly and eventually came to Canada and the US. So this is why I'm kind of saying back to the future, in that for Canada and the US, this is a relatively new procedure, but really it's been around for 30 years, at least in Japan, and subsequently very soon after that spread to Korea and China. In terms of the tools for ESD, these are some of them, but not all of them. These are different types of knives that we use. So you can see these ones have a water jet function, so we can inject. As I mentioned, we generally put fluid underneath the lesion to lift it up and make it safer and easier to remove. So these knives have really kind of revolutionized things and decreased the procedure time significantly as compared to the older knives that didn't have an injection function. These are two different types of knives that are kind of used like essentially you cut like a sword. So this is the cutting edge. The distal end is insulated, so it doesn't cut on that end. And these are hemostatic forceps. You generally run into bleeding during ESD or big vessels, so you have to be able to use these and be comfortable using these coagulation forceps. This is the electrosurgical unit, which you have to be familiar with and know how to adjust the settings depending on the location, the tissue that you're encountering. So you have to be quite knowledgeable and proficient in how to use and adjust the settings there. This is just an example of an ESD to show you generally what we do. So this was a lesion in the rectum. Again, we kind of examined it with different types of light to characterize it and predict the histology. And then we inject fluid underneath it. The first time we use a needle injector to kind of lift things up. And then you can see this blue dye underneath, which helps delineate the tissue planes. We use this little tiny knife and we're just incising. And then you can see I can inject with it fluid as well, which allows us to see this, the tissue plane better. And then we slowly incise and we repeat the incision until we can get underneath the lesion. Once we get underneath the lesion, the muscle is over here and then the superficial carcinoma is up here. And we basically just remove the fibers little by little using electrocautery and this knife. So you can see once you get underneath, it's actually fairly straightforward. It's probably getting underneath the lesion initially that's the most challenging. But once you're underneath, it's fairly quick and easy. And this is just the final little piece of connecting fiber. And in the end, we're able to get a nice specimen that we can pin down like this. And the pathologist can tell us the margins very nicely. And there's the defect at the end. So you can see these are the types of specimens you get, no matter how large it is. So it's very nice for the pathologist to tell you the vertical and lateral margins quite confidently. So in terms of ESD, the average length of stay generally in North America is done as an outpatient, or sometimes they're kept for 1 day, depending on the extent of it. There aren't any cases reported in terms of mortality, but obviously there's some reporting bias in this. But overall is generally quite safe. And as I mentioned, no reported mortalities, but you can extrapolate that it's probably quite rare, but it can happen.
Spouse, period.
And in terms of morbidity, the perforation rate varies anywhere from 0.1 to 1%, depending on the series you read. Delayed bleeding anywhere from 0.5 to 5%. And the cost at our center, because we generally do these in the operating room because anesthesia, we can only access it generally in the operating room, is fairly significant, $3,800. There's no formal funding for it, so it's funded as an EMR, about $1,000. So you can see as this being an obstacle in terms of to the implementation of it or really expansion of it in terms of being cost prohibitive. In terms of the advantages of ESD, as I mentioned, there's no size limitation for achieving an en-bloc resection. You can assess the vertical and lateral margins accurately. It gives you the maximum chance of obtaining an R0 resection, and it gives you the lowest risk of recurrence. So less than 0.5%.
Sorry, Rob. Dr. Menendez, could you please mute your mic, please?
So in terms of outcomes, so what are the outcomes and are there any practice changes as a result of ESD? This was a study and it looked at the clinical outcomes after ESD for colorectal neoplasia. It was a systematic review and meta-analysis in 2017. So it's gotten a little bit old, and it was when ESD started really coming to Europe. So some people in Europe at that time had been doing ESD for a couple of years. And it included 20,000 lesions from Asian countries and 2,000 lesions from non-Asian countries. So it gives you an idea right there, just in terms of the experience in terms of the procedure, how much experience there is between the two kind of areas. And in terms of the results from the Asian countries, R0 resection rate of about 87%, en bloc 94%, immediate perforation 3.8, but generally these are managed endoscopically just by clip closure. Delayed perforation, quite rare, less than 1%. Any adverse event requiring surgery, again, less than 1%. You can see from non-Asian countries at that time, the results were okay, but not as good. And really from this, it's not taking necessarily that the Asian endoscopists were better than the non-Asian, but that ESD is a safe and effective treatment for colorectal tumors when an experienced expert operator is available. And really at that time, a lot of the endoscopists out of the non-Asian countries have only been doing it for a year or two. And at that time, they didn't have any formal training either. Another study here in terms of esophageal ESD versus esophagectomy for superficial squamous carcinoma. This was a study that compared 120 pairs of patients that underwent ESD or esophagectomy for squamous cell carcinoma. And it included patients without obvious massive submucosal invasion based on the imaging from a database of endoscopic images. And to minimize the effect of selection bias, they used a propensity score matching. And here you can see the results, again, looking at overall survival, disease-specific survival, and recurrence-free survival. There wasn't any significant difference between the two. However, the 5-year metachronous recurrence-free survival was different between the two, which is expected. Generally for squamous carcinoma, it's a bit of a field defect. So these patients tend to develop other lesions in other areas of their esophagus. And that's why generally after endoscopic resection, they're usually under close surveillance. And the vast majority of the recurrences are mucosal and can be managed endoscopically. The adverse event rate, again, was different between the two, between esophagectomy and ESD, favoring ESD, which generally makes sense because of it just being a lot more invasive. And overall, these patients were followed for about 10 years in this study. Another study looking at colorectal lesions, and they wanted to see, does the treatment strategy change for these colon lesions that are called laterally spreading tumors before and after the implementation of ESD? So they wanted to look at if the introduction of it could improve the en bloc resection rate of these large LSTs. So LST-NG stands for non-granular, means they have this kind of smooth surface, and they tend to have a higher risk of superficial cancer. And they want to see if it reduced the surgical resection rate as well. So they looked at the cohort of 1999 to 2005. A total of 166 of these lesions were removed that were greater than 20 millimeters, and they had 161 patients. And the surgical resection rate was historically compared before and after the introduction of colorectal ESD. So before ESD, the unblocked resection rate for these lesions greater than 2 millimeters was only about 35%, and after ESD was 77%. And the surgical resection of superficial lesions, so ones that had mucosal carcinoma or superficial carcinoma, was 20%, and after the implementation of ESD was only 1%. And non-curative endoscopic resections for deeply invasive lesions beforehand didn't occur, and afterwards about 10%. However, the patients that had endoscopic resections and the histology showed deeply invasive carcinoma were able to still receive surgical resection that was curative subsequent to this. So this showed that the introduction of colonic ESD was able to improve the en-bloc resection rate and reduce the surgical resection rate of these superficial lesions. And since then, there's been a number of studies that have come out for esophageal, for gastric, and colonic lesions, really showing the utility of removing these via ESD and showing really the equivalence essentially to surgical resection for superficial lesions with good histology. And the arguments against ESD really are that it's time consuming. We don't have any formal training in North America. And conventionally in Asia, you start training with gastric lesions, early gastric cancers in the antrum, as this is generally the easiest area to start ESD, and the risk of complication is much lower there because the wall is much thicker. There's a perceived high risk of perforation, but as I showed you, that it's actually very similar to EMR. And people say, well, EMR is safe and effective. Why do we need ESD? And it requires, probably one of the biggest obstacles, I think, is that it requires expertise, at least at this point, of advanced endoscopic diagnosis, which is not taught in North America. Down the line with AI advancing, this may change, and the histology prediction used with AI in endoscopy is likely going to surpass that of endoscopists, and it will become standard practice. And this may not necessarily be as important as it currently is. So we have EMR and we have surgery, and then there's a gap between the two. And that's really the role of ESD, to fill that gap. ESD doesn't take over EMR, and it doesn't take over surgery. It really just allows you to cater the treatment better towards the lesion and the patient, rather than only having two choices. And the indications for ESD, this is from the American Gastro Association that kind of introduced the clinical practice guidelines a couple of years ago. And it's really the same for all areas in terms of esophageal, gastric, and colonic, lesions with high-grade dysplasia or superficial carcinoma, or lesions that are heavily scarred. Those are really the lesions that are best suited for ESD. So we'll go back to the cases, and we'll see kind of how we manage them. So the first case, the lady with type 3 achalasia, and this squamous lesion that we saw here that we predicted is going to be mostly mucosal with potentially a focus of superficial submucosal carcinoma. So this is the lesion, and these numbers just showed you my approach to the ESD. So I incised initially at the distal margin, and you'll see why that's important later. And then I came up to the proximal margin and incised there. And you can see the muscle fibers running up and down. That's the muscularis mucosa. I trace that area, and then I get into the submucosa. And you can see it's stained blue here. So the muscle is down at the bottom. The carcinoma is up here above us. And then we make this tunnel, and we go down to our distal incision. So you can see that little flap there. So we keep tunneling down, and there's our distal incision. So you can see why it was important that we made that initially, so we know when we're done. And then here's the defect at the end. So the patient was discharged home the same day, and she resumed a normal diet in 24 hours. She didn't require any narcotic analgesia. The final pathology was superficial mucosal carcinoma with one small focus in that little nub that we pointed out earlier of superficial SM1 carcinoma. It was well differentiated, no lymphovascular. And her last follow-up 4 years after that, she's had no recurrence and she's been cancer-free. And I will mention that it's important for all these cases, we discuss them at our multidisciplinary tumor boards and make sure that our oncologists, our surgeons, and everyone's on board, obviously, with these lesions being resected in this manner. The second case was the patient with the complex Barrett's history who had carcinoma in the past, had radiofrequency ablation and EMR, but still has persistence of dysplastic Barrett's. So this shows you the lesion here. This is kind of where it was located, just at the distal esophagus at the GE junction. So in this case, we initially marked the distal end just on the gastric side, and that's going to serve as our exit strategy or our exit area. So we incise that area circumferentially just below the marks, and then we come up to this area over here and make a small incision. And again, we trace it repeatedly until we kind of can get underneath the mucosa. And finally, we get underneath the mucosa and we really just dissect the submucosal fibers. And we're peeling it off the muscularis propria. So in this particular circumstance, we did it. Here's the tunnel showing you that going from the proximal end to the distal end and getting down to the gastric side over there. And we repeated this 3 times. So you can see the 3 different tunnels there. And afterwards, we then connect the tunnels. So we further dissect the submucosa completely. And then by doing this, we're able to remove a complete tube of the tissue in the esophagus. So you can see we're removing it with a grasper, and there's the defect at the end. We're kind of, the bottom end is on the gastric side. The proximal end is up here on the normal squamous mucosa, and this is the defect that we're left with. And her final pathology showed multifocal, low-grade, and high-grade dysplasia and extensive buried Barrett's. So here's the specimen here, kind of a tube of tissue that we put over a syringe. Then we cut it open and we pin it down for the pathologist. And here is buried Barrett's. So overlying is squamous mucosa, but underneath it, you can see this Barrett's. So this is quite problematic because if they develop carcinoma in this, it can be very difficult to detect, and they may present quite late, even though they have surveillance regularly. And this is high-grade dysplasia here. So she was discharged home the next day on full fluids and resumed a normal diet about 4 days after. She didn't require any narcotics, and her last follow-up 3 years after the ESD, she doesn't have any recurrence or any dysplasia. And this was the 66-year-old lady who had the signet ring carcinoma on that single biopsy. And again, we mark around the lesion because it can be difficult to know your margins during the dissection. And here we get underneath, we resected the lesion, and this shows you the histology in terms of the signet ring cells infiltrating into the lamina propria. And this is a normal stomach, so you can see very subtle in terms of histologically and as well endoscopically. And this shows you with high power, you can see the signet ring cells quite nicely. So she was discharged home the same day on a fluid diet, resumed a normal diet after 2 days, again, didn't require narcotics, and her last follow-up 2 years later, she's had no recurrence of her cancer. The final case was the 85-year-old lady with the previous colon cancers with this lesion here. So we removed it as well via ESD, and she did have superficial carcinoma just in this area here, which corresponds to this nodule. But the pathologist was able to tell us that it was completely clear, didn't have any high-risk features, and it was a curative resection. So she went home the same day without narcotics, and her last follow-up was 3 years after without any recurrence. So in terms of expanding ESD in Canada, we have to work on establishing formal training programs, which hopefully we will do in the coming year. Funding from the government, at least for us in Ontario, has been a challenge. It's something that we're working on to improve funding so we can expand this procedure, which really in the long run saves money for the healthcare system. It requires a culture shift from any GI cancer, meaning it has to have surgery, which we've done at our center. And I think you're also very lucky there to have Eric Lamb there, who does ESD and is an expert in it as well. And most procedures require anesthesia support. And that's, again, can be a challenge for many academic centers to get anesthesia support for endoscopic procedures. And just to briefly just go over our experience, we've done about 200 cases. And overall, our results have been fairly good with a good on-block resection rate of about 90%, a R0, so a complete histologically clear specimen in terms of any carcinoma, vertical and lateral, about 86%. We've had a few adverse events in terms of immediate perforations, which we were able to manage endoscopically. We've had a couple of delayed bleeds, but no delayed perforations. And as I mentioned, the single perforation, which we're able to manage endoscopically. So in terms of EMR, as I mentioned, overall, it's a good option for low-grade GI neoplasia or superficial carcinoma. And surgery is the best treatment for cancer with significant risk of lymph node metastasis. And ESD really closes the gap between EMR and surgery and is the ideal treatment for scarred lesions, high-grade dysplasia, and superficial cancers. And then I'll just close with this slide. These are many things that have been said about ESD, saying that, well, we have a lower disease prevalence of these superficial cancers. There's different definitions in terms of early cancer and dysplasia in Japan as compared to the West. We don't have a lot of exposure to ESD. We don't have confidence. We don't have training in ESD. Concerns about litigation in terms of applying this potentially risky new procedure in the West. However, this was actually what was said about EMR in 2002. So this was out of a paper explaining why EMR is not going to take off in the West, and we're really just looking for an excuse to do it. So this was in 2002. EMR is now done widely in academic and non-academic centers and is really, again, become the standard for, as I mentioned, superficial small cancers or low-grade lesions. So the hope is that we don't do the same thing that we did in the past, where we immediately dismiss something because we don't do it, and really embrace ESD and try to expand it in North America as it's already happening, and we don't want to take this kind of approach as we did in the past. So thank you very much for your attention and for joining.
Thanks, Rob. That was excellent talk. Right, so we'll open it up to questions amongst the group. Jennifer has a question here, but before we go on to ESD and subepithelial lesions, just wanted to ask a little bit about the second case, the one with the buried Barrett's, right? Mm-hmm. And how long did it take for you to do that particular procedure? I would imagine that after RFA, there's a lot of scarring, right? And that you have to be really slow in your technique in terms of resecting that lesion. So
that particular case took about 3 hours and a bit, 3 to 3.5 hours, if I recall. And as you mentioned, you're right in terms of the scarring. So that's one of the challenges with ESD. It's like you may not know how long it's going to take until you start, because if there's a lot of scarring, it can really increase the time exponentially in terms of the procedure. Something you may have thought would take, an hour. If it has a lot of fibrosis and scarring, that can easily double or triple your expected time. And that's also the case, with expert endoscopists in Japan. I remember a lesion we had booked for, I think it was 2 hours, ended up taking 12 hours plus, because they ended up being just completely scarred and fibrotic. And this was probably one of the best endoscopists who was doing it that I've seen, who does everything usually, quite quickly, things in under an hour most of the time. But this took nearly, 12 plus hours to complete.
I guess then that sort of segues into maybe the reason why it's not done in the West is because, I guess lack of, like you were saying, lack of a whole bunch of things on that list, right? But do you think that it may be different priorities in the West in terms of colon cancer screening, demanding high endoscopic resource utilization that's not seen in Japan. I'm not sure what they would do in Japan in that sort of situation.
Yeah, I think it's one of the challenges is our system and the demands and strains on our system. That's with kind of universal healthcare and kind of having to prioritize your resources or use your resources as efficiently as you can. It may not be the ideal in terms of the way sometimes we do things, but really we have to kind of same overall kind of look at the risk benefit in terms of our resources. So I think that's one of the challenges and will be one of the challenges going forward in terms of how things are funded and in terms of how much time is available to do these procedures.
Mm-hmm, mm-hmm. Okay, so we'll go on to Jennifer's question. Is there any utility for ESD in subepithelial lesions in the submucosa, for example, neuroendocrine tumors or lesions without a histologic diagnosis?
Yeah, so I think so for ESD, so there's an offshoot of POEM as well called per-oral endoscopic tumor resection. So for neuroendocrine tumors or other lesions that come from the muscularis mucosa, they definitely can be removed with ESD. And sometimes these lesions that they may not have a histologic diagnosis from the FNA, but are maybe suspicious based on the ultrasonography findings. We do remove them with ESD. If they arise from the muscularis mucosa. If they're from the muscularis propria, if you remove it via the ESD technique, you may have to do a full thickness resection. So remove the muscularis propria and essentially do a controlled perforation and then close it endoscopically. The other option for subepithelial lesions is to create a tunnel underneath the normal mucosa, kind of dissect the lesion out from the epithelium, and then remove the muscularis propria, leaving the epithelium intact, and then closing your entrance. So it definitely is used for subepithelial lesions. Definitely, the volume is for sure not as high as mucosal lesions, but it's definitely used in subepithelial lesions with, again, similar efficacy. And it's actually in the ASGE guidelines for approach to subepithelial lesions. ESD is definitely one of the treatment modalities that's recommended for those that arise from the muscularis mucosa, at least.
Mm-hmm. Yeah, I think a lot of those ASGE guidelines that you're alluding to has been published for many years, right? In terms of management of subepithelial lesions, but I mean, what's suggested really, I must say, is not really going on in many parts of Canada and the United States. I would say. Would you say that's fair?
Yeah, I'd say it's fair. I think they generally are, whether they are often are surveyed or they just have, a wedge resection for the gastric subepithelial lesions or thoracoscopic enucleation for some of the esophageal ones. But after, when I came back and started doing these, our surgeons are often busy enough with a lot of other oncologic cases. So if these can be removed endoscopically with the kind of definitive histology and often with curative results, there definitely have been supportive. And then if the lesion has high risk pathology, the ESD doesn't preclude them getting a surgical resection with lymph node dissection if required. So you don't burn any bridges by doing it endoscopically initially. And as I said, the group here, kind of after coming back and going over things with them, everyone's been generally quite supportive.
Mm-hmm. Great. So anybody in the audience, if you have any questions, you can press on your mic there. Any other questions from people on the Zoom platform? You can raise your hand or unmute and ask a question. Okay, I guess no questions, right? Well, I'd like to thank Rob for giving us a great talk on ESD and really looking forward to you coming next week and doing some cases with us and showing some of the techniques that you do in Kingston. Thanks very much.
Thanks, Eric, and thanks everyone.
Yeah.
I'll see you next week.
All right. Bye.
All right. Take care.
All right. Okay. Good. Pretty close to it, eh? Yeah, cool stuff. Yes.
It's fun.
Yeah.
It's amazing.
The Japanese are also very good at product.